Hello everyone. Hello. Welcome to this session on pediatrics. Okay. Today we are going to discuss something very basic. The topic for today is basics of diarrhea. Okay. We are going to discuss basics of diarrhea. All right. So we are not going to go in details about any of the acute diarrhea or chronic diarrhea or persistent diarrhea, but we'll be going into the basics. Okay. So talking about the basics, first I would like to tell a few points. First, we need to know what is the definition of diarrhea. Okay. Definition wise, it is defined as excessive loss, excessive loss of fluid and electrolyte in stool. Okay. Excessive loss of fluid and electrolyte in stool is defined as diarrhea. Okay. uh, and in this there is something called as acute diarrhea. So in acute diarrhea, what you need to know is it lasts for less than 14 days. All right, that is the basics. And the onset is sudden, and the consistency of stools is usually excessively loose stools. Okay. Now there's a limit for these, like basically what you're going to say, more than 10 ml per kg per day in infants. Okay. And for older children it's more than 200 grams per 24 hours. Okay. Any age more than 1 year, that is after the infancy, more than 200 grams in 24 hours, okay, is acute diarrhea. Like that is the limit. Okay. So what happens if the episodes are lasting for more than 14 days? For more than 14 days, there are different terms called chronic diarrhea and persistent diarrhea, which is based on etiology. This will speak in further videos. Okay. We are not going to go in details today, only basics. All right. Now coming next, let's know the normal stool output. Okay. We have two limits, right? So it's very easy to remember now. Normal stool output is 5 ml per kg per day in whom? In infants. In infants, it is 5 ml per kg per day, and in older children, it is 200 grams per 24 hours. Less than or equal to, 200 grams per 24 hours. Now as you know, there is a small intestine and there is a large intestine. Okay. Now any disorder which affects the small intestine causes voluminous diarrhea. Why? Because the absorptive surface, which is the most important, is in the small bowel, is voluminous diarrhea. Whereas if colonic absorption is there, it is a low volume diarrhea. If colonic absorption is affected, it causes a low volume diarrhea. Now a little small note on what is dysentery. Dysentery. Okay. Dysentery is a small volume. Dysentery is a small volume, frequently bloody stools, okay, with mucus, tenesmus. Tenesmus is a feeling of incomplete evacuation. Tenesmus and urgency. Okay. It is predominantly a symptom of colitis. It's a predominant symptom complex of colitis. Okay. All this urgency, mucus, tenesmus. All right. Now going next is a little important concept. It's basically about the mechanisms of diarrhea, okay, and it is quite important for you to understand this as a postgraduate. All right, and let us go into details about mechanisms of diarrhea. Okay, actually it is supposed to be told as a table. uh, so as I cannot draw the table, which is, it's quite big table, I cannot draw the table overall, so I'll be like listing out each one of them. So first in the first thing I'm going to tell you about the mechanism. First point is going to be about the mechanism. Second point is going to be about the defect. What is the defect? Number 3 will be what are the findings of stool examination. Okay, what are the findings of stool examination? And next I'm going to give you a few examples, and in the last I'll be commenting, okay, some comment or something. Okay, so let us start with the first one. Secretory mechanism of diarrhea. Okay, in this what is happening? There is decreased absorption. Defect, what is the defect? Decreased absorption, increased secretion, and defect of electrolyte transport defect. So what is the stool like? Stool is watery with normal osmolality. Okay, and the ion gap in the stool will be less than 100 milliosmoles per kg. In the examples we have cholera, ETEC type cholera, carcinoid syndrome, okay, VIP, vasointestinal VIP secreting tumors, neuroblastoma, Clostridium difficile infection, and Cryptosporidium in AIDS will also cause this type of diarrhea. Now what is the comment which I want to give? Now in a secretory diarrhea, it's related to the secretion, right? So it's not related to any osmotic pressure or anything. So if you even fast, it will persist. So it persists even with fasting. Even with fasting it persists, and there are no stool leukocytes. So this is about secretory diarrhea. Okay, shall I go to the next one? The next one we'll be coming to is osmotic diarrhea. Okay, osmotic diarrhea. In osmotic diarrhea, the defect is what? There is maldigestion. Okay, there is defect in electrolyte transport. There is defect in ingestion, that is, there is ingestion of unabsorbable substances. Unabsorbable substances you ingest, you will get osmotic diarrhea. So what is the stool examination going to show? It is watery, acidic, there may be reducing substances present. Okay, there is increased osmolality, that is ion gap will be more than 100 milliosmoles per kg. Examples, there is lactase deficiency, okay, glucose or galactose malabsorption, okay, lactulose abuse or laxative abuse also. Laxative abuse can cause this. Now if in this condition you stop the intake, so fasting is done, if fasting is done, the stool will subside. and again here there are no stool leukocytes. All right. Now third mechanism of diarrhea, increased motility. Increased motility. Increased motility, the defect is decreased transit time. Okay, decreased transit time. What happens to the stool? Stool is loose to normal appearing. Okay, and it is stimulated by gastrocolic reflex. All right. Examples is IBS, thyrotoxicosis, post-vagotomy dumping syndrome. Post-vagotomy dumping syndrome. Okay. Now, infection can also sometimes contribute to increased motility. All right. Infections can also sometimes increase the motility. Okay. Now going next to decreased motility. Okay. I'll now talk about decreased motility. Now you may be thinking like, why decreased motility in diarrhea? But you will understand. In decreased motility, what is happening? There is a defect in neuromuscular units. There is a defect in neuromuscular units, and this causes stasis. This stasis causes bacterial overgrowth. So in this, what happens? In this, the stool will be normal appearing usually, sometimes maybe loose. Okay. Now this is seen in something like pseudo obstructions. Okay. Blind loop syndromes. And the cause of diarrhea here is possible bacterial overgrowth. All right. You have to remember, even decreased motility can also sometimes result in diarrhea. Okay. Coming next to decreased surface area. Decreased surface area. Okay. In decreased surface area, the defect is decreased functional capacity. Therefore, surface area is decreased, there is no absorption, the diarrhea will be watery. Okay. Occurs in examples like short bowel syndrome, celiac disease, rotavirus enteritis, rotavirus infection. Okay. In this, the treatment is usually elemental diet with parenteral alimentation. Okay. Coming to next, the last one, mucosal invasion. Mucosal invasion. This is the last mechanism, mucosal invasion. Now, what happens in mucosal invasion? There is defect. What is the problems? There is inflammation. There is decreased colonic absorption, reabsorption. Okay, and there is increased motility. All this result in diarrhea. Therefore, in this, what will happen? Blood and mucus will be present in stool. Causes are salmonella, shigella, okay, amoebiasis, okay, Yersinia infection, and one more very important one is Campylobacter. Okay. Now this is evidence of dysentery. In a stool examination, we'll get dysentery like. So we'll definitely see blood, WBC, and mucus in stool. So this is the picture of dysentery. Okay, done. So this was all about the mechanisms, all right, various mechanisms of diarrhea. Okay, now coming next to important, let's shift the importances. We are going to talk about the clinical types of diarrhea. What are the clinical types? And as you have learned the mechanism, these are going to be very simple for you. Basically, it's similar, like it could be similar to the understanding of the mechanisms. So we have three types. Number one is secretory, number two is osmotic, and number three is invasive. Okay, let us talk about each. Number one, secretory. So in secretory diarrhea, when does it occur? It occurs when the intestinal epithelial cells of the intestine, there is a problem with solute transport system, and they are in an active state of secretion. All the solute transport mechanisms are in an active state of secretion. Okay, it can be caused by a secretagogue. Secretagogue. Okay, secretagogue. This secretagogue is like, for example, cholera toxin, which binds to the intestinal epithelial surface and stimulates production of CAMP. You have learned this in microbiology, CAMP or CGMP. Okay. Now some other diseases also can cause secretory diarrhea, like congenital microvillus inclusion disease. Okay, this is a secretory diarrhea which is associated with an exogenous secretagogue. Not associated with exogenous, not associated with exogenous secretagogue. Okay, it is a secretory diarrhea which is not associated with a exogenous secretagogue. Therefore, how is the diarrhea here? It's a large volume diarrhea. And it persists even with fasting. And the ion gap, like we said, ion gap is less than 100 milliosmol per kg. Now, how do you calculate this ion gap? If someone asks you, it's basically stool osmolality minus stool sodium plus stool potassium into 2. Okay, this is how you calculate ion gap. Okay, so if stool osmolality is increasing, the ion gap will definitely increase. Okay, so coming to the second one, that is osmotic diarrhea, clinical type. Osmotic diarrhea, in this it occurs after ingestion of a normally poorly absorbed solute. So poorly absorbed solute, if you ingest, it will definitely increase the osmotic load. So for example, magnesium, phosphates, lactulose, and some laxatives. Okay, sorbitol. Okay, or sometimes what happens, this is one of the things, one mechanism in this thing. Another thing that can happen is, sometimes it's not, some normal things are not well absorbed due to small bowel disorder, like lactose with lactase deficiency. If there is lactase deficiency, lactose won't be absorbed. Or glucose with rotavirus diarrhea. Is not absorbed. Okay. In this cases, what will happen definitely, if there is a osmotic diarrhea, so it will obviously take in all the water is going to go into osmotic diarrhea. So we are going to get hypernatremia as a complication very commonly. Hypernatremia. Okay. This is in what you need to know is, compared to secretory diarrhea, this is lesser volume. Okay. And it stops with fasting. It stops with fasting. Okay. And osmolarity ion gap, we said how much it will be? It will be more than 100 milliosmoles per kg because of high osmotic content of the stool. Coming to the last type, that is the invasive diarrhea. Invasive diarrhea, in this what happens is the intestinal mucosal cells are invaded by microorganisms which set up an inflammatory reaction. Okay, they set up an inflammatory reaction. Okay, this inflammatory reaction can result in blood and mucus to come in stools. And the complications of invasive diarrhea can be intestinal perforation or toxic megacolon, or rectal prolapse. Okay, sometimes due to the electrolyte disturbances or the septicemia picture, convulsions can happen, sepsis and HUS, hemolytic uremic syndrome. All right, so this is about the types, clinical types of diarrhea. Okay, so this is done. Now coming to the last topic of our in this video is the differential diagnosis. Differential diagnosis of diarrhea. This is a very tedious list, so I am going to speak about only the important things. What you need to know is, we'll divide this into three. Okay, we'll divide it into an infant, we'll divide it into a child, and we'll divide it into adolescent for ease. Okay, and I'm going to mention only the first two of the, this is an exhaustive list which is present in the gastrointestinal textbook of gastrointestinology, but we'll go with very common causes. All right, yeah, so coming to the infant, okay, coming to the infant, we have causes for acute and causes for chronic. Okay, let me do this thing. Let me make a table. I think in that way it could become easier for you. Let us see. Okay, this here I could write about okay, this is infant, this is child, and this is adolescent. Okay, in this we have acute and chronic causes. In each we have again two separate things. Okay, this entire is chronic, this is common, this is rare. Common, rare. Okay, I think this way I can fill some things. Let me see. Yeah, so common in infant, common causes in infant. What are the common causes? Number one is, sorry, so what are the common causes? Number one is gastroenteritis, acute, common acute gastroenteritis, that is viral more than bacterial more than protozoal. Number two, infants, right? So systemic infection, any systemic infection can result in diarrhea. Okay, acute diarrhea. Okay. Third would be antibiotic associated, because infants, any cough, fever, just people put them on antibiotics, very common. And very you'd be surprised to know overfeeding can also cause as common cause of acute diarrhea. What are the rare causes in an infant? We need to know primary disaccharidase deficiency. Okay. Second, Hirschsprung's disease, Hirschsprung's, okay, in which there will be toxic colitis sometimes. Number 3, adrenogenital syndrome. That's it. I think that is more than enough. Adrenogenital syndrome. And number 4 is opiate withdrawal. Opiate withdrawal can cause. Okay. Now coming to chronic. Okay. Chronic causes. Infant chronic causes, but common. So number 1, post-infectious secondary lactase deficiency. Okay. So after an infection, chronic infection, there may be lactase deficiency. Okay. That is acquired. Then cow milk protein allergy or soy milk allergy. Then excessive fruit juices. Sometimes you keep giving, some parents keep giving excessive fruit juices. Okay, they keep giving and giving and giving. And celiac disease is also one of the causes of chronic. This is chronic, don't forget. And last but not the least, you need to remember is cystic fibrosis. Okay, coming to rare causes. Now it is known as inborn errors of immunity. Okay, so inborn errors of immunity, that is primary immunodeficiency, and autoimmune enteropathies, autoimmune causes. Then we just now discussed one, microvillus inclusion disease. Okay, and congenital transporter defects. And last one is short bowel syndrome. Okay, so this is about the causes, differential diagnosis in infant. Coming to child, now it will become easy because we are discussing common causes in a child with acute causes are gastroenteritis, definitely, food poisoning, systemic infections comes a little later here, no, systemic infections. Okay, and then antibiotic associated. Okay, coming to rare causes, toxic ingestions, HUS, and intussusception. Okay, this is about the acute. What about the chronic ones? Chronic ones causes may we have again post-infectious, secondary lactase deficiency, all right, IBS, okay, IBD, celiac disease, okay, cystic fibrosis also comes, but it's rare. In the rare ones, again we have primary, that is inborn errors of immunity, that is primary immunodeficiency diseases, secretory tumors. This is all chronic causes, don't forget. Okay, chronic. Eosinophilic gastroenteritis, and something which is called as pseudo obstruction, Ogleich syndrome and all that. So pseudo obstruction. Okay, coming to adolescent, it's even more simpler. It became common causes. Again we have GE, we have food poisoning, and we have antibiotic associated diarrhea again. Okay, coming to rarer causes of acute, hyperthyroidism. So this is all to help in your differential. Okay, and one more is appendicitis. Appendicitis can present as an acute diarrhea sometimes. Okay, coming to chronic causes, common is IBS, IBD, okay, laxative abuse in anorexia nervosa, adolescents, right? Anorexia nervosa, okay, adolescents, so you have to remember this. And then in rare causes we have bowel tumors, primary bowel tumors, secretory tumors, Addison's disease, Addison's disease, okay, and one more cause which you can write is appendiceal abscess, okay. I know the list is quite boring, quite exhaustive, but this a diarrhea is a very common manifestation. First of all, an acute or chronic or in infant, child, and adolescent. This is a very lovely table, okay, so which can help you in knowing the differential diagnosis of various types of diarrhea which are presenting in with different age groups, okay. So this will conclude today's topic, which is about the basics of the entire diarrhea, okay. We spoke about the definition, we spoke about the mechanisms, we spoke about the clinical types, all right, and then we spoke about the differential diagnosis, okay. If you find anything missing or anything wrong in this, please share in the comments. And like always, I would like to say thank you for listening to my session. I know it can get tedious and boring, but this is for the postgraduate learning. That's why I am Dr. Waheed Hussain, okay, and that's why I am taking this initiative for uh, so that you know we can have a postgraduate kind of learning. And today's sources are from textbook of Paediatric, Gastroenterology, okay, Hepatology and Nutrition, okay. This is publication is Springer's, okay, and the authors are Guandolini, Dhawan and Bransky, okay. And another one of my source was IIP textbook of Paediatrics, IIP textbook series, specialty series, basically IIP textbook of Paediatrics, okay. So that's all for today. Thank you very much. Yeah, bye bye. And I'll follow up the further videos of acute diarrhea, persistent diarrhea and chronic diarrhea. That will take some time, okay. So yeah, thank you so much. Okay, bye bye, goodbye, good night.